enzyme replacement therapy is basically one of the most successful forms of gene therapy, which is to replace an enzyme that the body doesn't make, that it needs in order to provide a system of breaking down products in the cell that is part of normal cellular processing. So without the enzyme, you get buildup of proteins that then essentially clog up around bone, around linings around bones, in organs, liver, spleen, and also that can happen in the brain. So the idea that you could give back that enzyme to the body, that you could give it in through the blood, that it would get to all of the organs in the body, and then help break down those proteins, and they basically disappear, and then the organs go on to function normally. So the one place that that doesn't happen is in the brain. And not that it couldn't work in the brain, but that when you give the enzyme intravenously, it doesn't get to the brain. And the reason for that is that the brain, which we have a model of here, has the equivalent of what I call has the equivalent of a lining around it, around the surface of the brain, and then here's the back of the brain and into the spinal cord. And there's a lining that basically provides a protection, a barrier, so that the brain has a sense of an extra protection against foreign substances that would come into the body. If you look deeper into the brain at some of the structures, there's also a lining. The lining extends through there. So when the enzyme replacement takes place, it doesn't get into those areas of the brain. When you give the enzyme intravenously, that barrier around the brain prevents the enzyme from getting into the brain. And so the consequence of that is that these breakdown products are not further broken down like they are in the rest of the body. And so what happens in time is with the buildup, then that can lead to problems in the brain. Things like memory, concentration. I think of it in terms of the processor. Our brain's a big processor, and how well do you process information? And so the thinking cells are connected by long cables, and the cables carry information from one thinking cell to the next. And so these proteins interfere with that. And so the biggest challenge is how do we get the enzyme into the brain, because if we know that if it gets into the brain, then we can have breakdown of those products. The fluid basically bathes the brain all the way around the outside and the inside and through all the surfaces, and keeps, if you think of it as keeping the brain moist, and also the spinal cord, to keep the spinal cord moist as it goes down. So if you have a way of accessing that fluid, then you could potentially give your enzyme into the fluid, and it slowly percolates around and has then the ability to break down those proteins that are sitting there. And so one way, this is a problem actually that we see in all the neurological diseases and in brain cancer, where we want to give a drug that acts in the brain, but many don't cross this barrier, this blood-brain barrier. And so one route that's been used for a very long time, both for children and for adults, is to put a small needle, as shown here in the picture, small needle in between the bones in the back and into that fluid, and then inject the enzyme or the drug directly into the fluid. And then over time, it gets carried around the brain, along with the spinal cord, and in the case of Aldurazyme, we know that it gets into the brain, so it moves just also from outside, but also inside the brain. So it really provides an access route, which is fantastic. So just like you saw in the body, there's no difference. This enzyme works on those abnormal proteins and would immediately break them down. And the way I think of it simply is just that those thinking cells connected by the cables now don't have those abnormal proteins on the surface. And we know, especially from brain cancer work, that if you just take the pressure off of the cables, then information will flow again. And certainly our hope in this is that we would see first of all, recovery in any situation where there was some change in neurological function, and for younger children, the prevention of any problems in the brain, just like we're seeing with the effect of the enzyme in the body. For example, so in brain cancer, it's the most common route to treat cancer that has spread, in fact, to the lining of the brain. And we've been doing that for 30, 40 years. And so the other is what most people will think of commonly as women who are having babies who go in and want to get anesthesia and pain control during childbirth. They have a needle placed exactly in the same way, and then anesthetic is given through there, and that causes the drug to basically numb the nerves as the baby's being delivered. So it's extremely common. In fact, women beg for it. so it's something that a lot of people can relate to. It's easy. If done safely, hopefully pain-free. First of all, it's a drug that Ryan and the other children and adults take. It's great that and so we know that their body tolerates it. So there's really, as far as we're concerned, there's really been no issue whatsoever about the safety of giving the enzyme into the fluid. And that also is backed up by a lot of studies that were done in animals to prove that it was safe. So we really don't have any concerns whatsoever. And if you think about the benefit versus any potential risk, the benefits far outweigh any potential risk of the drug. The intrathecal therapy or procedure itself has the potential risk of bleeding at the site, introducing infection, or having a headache because of the way that the fluid flows. Having said that, because it's so common and because it's done so carefully, done in the hospital with experts, and here we do it with radiology, who do this all the time with the guidance of imaging so they know exactly where they are, what they're looking at, the risks are very, very low. And again, the most important thing is that the potential benefits so far outweigh whatever the risk would be that it's really in a very low risk category. We rely heavily on our long-term memory, which is something that develops starting at around age 4, and then you build on it over time, and that's one area of the brain. Short-term memory is our ability to learn new information and remember it. And so short-term memory has a lot to do with concentration, paying attention to what somebody's telling you, not having your mind on too many other things. But then there's a real neurological storage, information storage piece where you have to take what you've heard and put it into an area of the brain and then be able to retrieve that. And so that's what we think of in terms of the thinking cells. There are cells that's their job, and that when you try and retrieve it, they send information, to other areas of the brain, so that you could, for example, tell us a story that you had read, or recount a conversation, or remember a phone number, those kinds of things. The other is the way that, so in terms of that, we would anticipate that if those circuits are intact, that you should immediately be able to go back and store that short-term information. And so simple tests like we do in the clinic for brain cancer patients is you give someone 3 objects randomly, then ask them about that 5 minutes later. That's a standard test of whether you can recall information. And then looking 5 minutes later is, did you store it in an area that the brain can then retrieve it? And so that's one extremely important area of just general function in life, to be able to have good short-term memory. The second probably fits into that, but that is equally important, is the ability to process information that you hear. So taking in, for example, if someone asks you to do something, and being able to figure out the steps along the way that you need to do in order to do that. And so, we think of that as similar to a computer. And if you think of a computer that runs slowly, that you might get to the piece you're going to, but it's not quick. And so, again, those are neurological functions that can be impeded by abnormal proteins that are along these tracks. So a lot of it's subtle. And so if you build up short-term memory problems and you learn to compensate for it over years, you may not necessarily see that there's a problem with it. And especially someone who's really intelligent, that you can compensate for short-term memory, or you write things down and things like that. But at some point, the buildup of these proteins is too great for you to be able to get around that. And so my personal feeling about it is, and we'll see what the long-term data shows, is that it still shouldn't do permanent damage in the brain. You should be able to go in and have those, basically like cleaning up and have the circuits there intact. And we know that that's true in a lot of the primary brain cancers that we treat. And that's, it's a good test of that, is if you can remove those cells, and it's the equivalent here of just abnormal material along the nerves. If you can remove that, then in fact the circuits are fine underneath it, and that's what we're hoping. The other is the buildup, as we talked about the line, that you can have similarly build up along the surface. And so even in those first few treatments, the idea would be knock all of that out of there, clean it off, that you leave the surface of the brain perfectly intact, no problems whatsoever. And then future treatments then will have a much easier time of getting through. Similarly, along the spinal cord, if you have buildup of, it's sort of like crusty material, and then if you can break all that down, then you have even freer flowing fluid. So our feeling is that the earlier you would start treatment, now looking back, the better. But that doesn't in any way mean that we can't expect for you to be able to tell us that you see improvement. And the only thing we're sort of waiting on pins and needles to figure out is it already. So subtle changes that you're already noticing are real. That's the thing. And even though we joke about us being biased, it's things that, the way that the brain works, things that you couldn't do, you couldn't do. And the brain can't do better than the best that it can do. You can't improve it beyond what it's basically capable of doing. And I don't mean that in a negative way. Of course, if we read more, you learn more of that. But this is about what the actual physical capability of the brain is. So if you notice an improvement, it has to be because something has changed. You can't get it any other way.
Good point.
But again, you're in this for the long haul.
Yes.
And I had my graduate supervisor told me when I was doing an experiment many years ago now, which I always remember, and you just reminded me, is he said, the problem with our generation, and I think even more so for your generation, is that we're a product of the TV generation, that you want the answer in an hour.
Right.
And that you're unsatisfied and it was a bad outcome if you don't know the answer in an hour.
Right.
But I think what you're teaching us is that this is a lifetime.
Right.
And that life can be good all the way along, but that you're looking for something better. And it's the same thing in the brain. Just, we don't accept the fact that the brain can't be better than it is.
Right.
Because we know there is something we can intervene with and then make it better. Uncover, it's literally like uncovering those areas of function that are just slowed down at the moment. This IT so exciting for us is that it proves that the circuits are perfect. That, one thing that everybody worried about is you're going to do long-term damage and not be able to get those areas of the brain to work again, which, the prediction from the study investigators was that doesn't make sense. It's just like crustiness on the surface. It shouldn't kill the nerves. It shouldn't kill the thinking cells. And so, what we talk about in the brain tumor world all the time is, coming from Boston, is, like a big nor'easter hits, and so here's the train, here's the track, and you get the snow on the track, and that train can't move and can't get to the next place. But as soon as the snow is off, the train is fine, the track is fine, and everything proceeds normally. And that's really, it's a good visual for what we really are hoping that happens here.
simple. When I first heard about it, I was really nervous, but when I went and started getting it, it got really easy because it's not as bad as some may think. It's just a really short procedure that only takes about 15 minutes, so it's nothing to worry about. No, it doesn't hurt because we put this amla cream on first, and then they give me this numbing shot, and once after the numbing shot, I don't feel anything. Really, I don't feel the numbing shot either because we have the amla cream on, so I don't feel anything really. I just feel a little pressure, but it's nothing to worry about or feel pain.
All right, Ryan. So let's run through a little bit of the exam.
Okay.
Make sure everything's going good and about the same as it was last time. Okay. I want you to tell me a couple of things I asked you to remember earlier, so that we can test your memory.
Okay, green, bowling, and then the light stick.
Very good. All right. I think you're ready to go.
I'm feeling good, just nervous a little bit because I get nervous still, even though it's a good process, but I'm feeling really good because it helps out. It's not a big deal because really they just put the amla cream on and then they give the little numbing shot and then you don't feel anything. It's just a little pressure, but nothing to worry about.
You shouldn't feel this even burn, but this will give you some a little bit deeper as well.
Okay.
But there was the stick. You might feel a little burning under the skin.
Okay?
Yep.
You're doing great. Breathe.
You're going to feel it a little bit deeper now.
Okay?
Yep.
What are your plans for the weekend?
Just relax, really. No trips this weekend.
Just hanging out?
Yeah, just hanging out. No trips to friends' houses or anything like that. No trips to Tyler. You know I did drive to Tyler, right?
By yourself?
Yeah.
Remember the first time that I was just squeezing your hand?
Yeah, you were squeezing my hand more than I was squeezing yours.
Keep your second off.
More like a big sister.
Doing okay?
Yep.
Seeing it on TV.
I never watched it, so I didn't know anything.
The procedure we just did was a fluoro-guided lumbar puncture. It's a pretty standard procedure. It's relatively safe. We use X-ray to guide a small needle into a patient's lower back. Once we get the needle in place, we can drain off a little bit of fluid if it needs to be obtained for lab purposes. And at that point, after the fluid's drained off, we inject the medication. It's relatively painless. We give the patient a little bit of numbing medicine, lidocaine, in the skin before we start. There's very little radiation involved. It's just enough to confirm that our needle is going in the right spot. Yeah, patients are completely awake, alert. As you saw during this procedure, sometimes we have to reposition the patient during the procedure. Not a whole lot of pain involved. That's about it.
All done?
All done. Time to go get elevated and sleep.
You okay? Yeah. You promise?
Nice having you.
Thanks.
Take care.
Thank you too.
See you later.
See you later. Thank you very much.
Thank you, Dr. Stehel.
The procedure went really good. It didn't hurt. It didn't bother me or anything. They just took the amla cream off and cleaned the area, gave me the numbing shot, and then they looked at my back through an X-ray machine to see where they wanted to give the lumbar puncture, and then they just gave me the lumbar puncture, and I didn't feel anything. And after they gave me the lumbar puncture, they just took some spinal fluid out, and that took a little while, but it went well. And then they gave me the shot, and just took it some time, and everything just went really smooth.
Today he was very relaxed, and we talked through the entire procedure, and he did really well. You know, Ryan is just going to keep going and going and going. He's not going to leave any stone unturned, and he is going to do well as he has for the last 24 years. The progress that he's made, not only for himself but for other patients with mucopolysaccharidosis, is it's hard to measure because we don't really know how many patients will be touched by all that he's done so far.
Today's Friday, the day after I got my lumbar puncture yesterday. I had a great night last night. Since IRB says that I have to stay the night after the lumbar puncture, I just went up to my room and just watched a bunch of movies on my laptop, updated Facebook. Right now it's about 9:45, which the doctors and nurses said that they are getting the papers ready to check out and everything. So I'm just getting ready to check out and go try to have another good day and everything outside of the hospital and try to have a normal day. And I'm going to go to the Rangers ballpark in Arlington to buy Rangers tickets. So it's no big deal because I just had a lumbar puncture. It doesn't mean I can't do anything the day after. I'm just going to try to have a normal life and not have any headaches or backaches or anything like that.